Hello friends, today we will see a lecture on spirometry. I have made video in Hindi language, now I am making in English language. So one thing comes in our mind whether spirometry and pulmonary function test both are same or not. This is common misconception that PFT and spirometry is same, but it is not. As name suggests, pulmonary function test is assessment of whole respiratory system. So it includes spirometry, lung volume ventilation, which measures total lung capacity, residual volume, and ratio. Diffusion capacities, blood gas analysis like arterial blood gas pulse oximetry, cardiopulmonary exercise test, some specialized tests to measure respiratory muscle functions like MIP, MAP. Exhaled nitric oxide, commonly called FeNO. Then force oscillatory technique like impulse oscillometry. So complete basket makes pulmonary function test. One part of it is spirometry. So today we will discuss spirometry. So before going to spirometry, we should understand physiology. Physiology, which we read in our MBBS first year. So what is tidal volume? Volume is the amount of air inhaling or exhaling. That is tidal volume. Okay. So after normal inhalation, can we take more breath inside the lung? Yes. By forcefully, if we take more breath inside, more inhalation, so it reach up to total lung capacity. Total lung capacity means amount of air which cannot be added after full inspiration. So we inspire, and after that we cannot take any further air. That capacity is total lung capacity. Okay. So after normal tidal breathing, how much air additional we can take, that is inspiratory reserve volume. So inspiratory reserve volume plus tidal volume makes it inspiratory capacity. Okay. Once we are taking tidal breathing, can we exhale more? Yes, by forcefully. So suppose we are taking breath, can we exhale more? Yes, by forcefully. Like, so maximum we can exhale, and after that, if there is no further exhalation, that amount of air left in the lungs is called residual volume. So residual volume cannot be expired by a normal individual. So that is residual volume. So after normal tidal breathing, the additional air which can be expelled through forcefully, that is expiratory reserve volume. So expiratory reserve volume plus residual volume is make functional residual capacity, which is air left in the lung after normal tidal breathing. So we are taking normal tidal breathing, and after normal expiration, the amount of air left in the lung is functional residual capacity, which is RB plus ERB. So RB cannot be expelled with any method. Okay. So in spirometry, what we are doing, we are just blowing in the spirometer. We are first inhaling and exhaling. So whatever air we are taking and exhaling, that can be measured by spirometry. But the air which is not, we cannot inhale or exhale, that is residual volume. So spirometer cannot measure residual volume. And as we know that FRC is ERB plus RB, but we cannot measure RB, we cannot measure FRC also. And third thing is total lung capacity, because we cannot measure residual volume, so we cannot measure total lung capacity by spirometer. So spirometer what indices we can measure, which is there we can blow, like vital capacity, ERV, IRV, ERV, and of course tidal breathing, tidal volume, that can be measured by spirometry. So main important component is vital capacity. So what is vital capacity? Vital signs, vital signs, BP, pulse, Vital signs means which is essential for life. For lungs, vital capacity is very essential. It means that is the capacity of lung which can expire or inspire maximally, forcefully. If we are taking normal tidal breathing, maximum inspiration, and after maximum inspiration, how much air we can expel forcefully, that is our vital signs for lungs, that is vital capacity. Amount of air which can be exhaled after maximum inhalation, that is vital capacity. So vital capacity is very important for spirometry. So there are two vital capacity. One is forced vital capacity and another one is slow vital capacity. Okay. So forced vital capacity, how much fast we can blow, as we blow on candles. Okay. Rapid. And this is for prolonged expiration. So rapid and prolonged expiration, maximum expiration, that makes forced vital capacity. In slow vital capacity, we are not taking this part, not rapid, just blow, just expiring, maximum expiration. That is slow vital capacity. If person is healthy, then slow vital capacity and forced vital capacity are safe because patient can inhale maximally and exhale maximally. It should be both, either forcefully or slow. But if patient is having small airway obstruction, like a emphysema, so inside emphysema, what happens when patient is expiring? So because of loss of elasticity, small airway collapse at the end of expiration. Say for example, if patient is inhaled, and after expiration, expire. So before completing the expiration, his small airway get collapse. So we cannot expire maximally. So in that case, forced vital capacity will be less as compared to slow vital capacity because of air trapping. Air trapping, we cannot blow. This is seen in emphysema. So indication of spirometry to evaluate respiratory disease. This is just ECG of a pulmonologist. Cardiologist is doing ECG for almost for all patients to rule out cardiac disease. Like that, we should do spirometry in all respiratory diseases for screening purpose, whether it is obstruction or restriction. Pre-operative evaluation, whether patient will get post-pulmonary complication or not. Then follow-up of obstructive restrictive pulmonary disease. By treatment, whether patient is getting responsive treatment or not. So 3 monthly, 6 monthly, 1 yearly, we have to follow whether treatment is responding or not. Important thing is contraindication. So it is important to know when to do, but it is equally important when not to do spirometry. In case of active hemoptysis, case of pneumothorax, large bulla, because there's sudden pressure change, which can lead to rupture of bulla, will cause pneumothorax. Recent myocardial infarction or pulmonary embolism within 4 weeks. Acute abdomen, chest pain, nausea, vomiting. Cataract, recent CNS surgery within 4 weeks. Dementia, confusion. Patient will not understand. Patient will not follow your command. Confused patient. Active pulmonary infection, very important. So before doing spirometry, just look at X-ray, and we have to rule out active pulmonary tuberculosis. If you do spirometry in active tuberculosis, then whole atmospheres will be infectious. So we should avoid spirometry in case of active infection and of course pregnancy. So we should not do spirometry in this patient. So once patient come for spirometry or we advise for spirometry, we should advise that he should not take any long-acting beta-2 agonist like formoterol, salmeterol 24 hours prior to spirometry. Otherwise, it will give false report. And long-acting muscarinic antagonist about 36 to 48 hours. Because these two medications most commonly being prescribed in our OPD for COPD or asthma or any respiratory diseases. So by and large, every patient whom you are advising spirometry should ask to hold to not to take any inhaler for 24 to 36 hours prior to spirometry. And these are the general, like no smoking, vaping, water pipe use within 1 hour, because it may affect spirometry report. Do not exercise, jogging, bicycling, fast walking 1 hour prior to the test. It will affect your report. Do not wear restrictive clothes that may interfere with taking deep breath, because patient has to take deep breath, maximum inhalation. If tight clothes are there, he cannot take deep breaths. So ask patient not to wear tight clothes. These small things were very important for doing spirometry. Now, technique. One must understand that at least three minimal acceptable FVC maneuver we should do. FVC means force vital capacity. Minimum three acceptable, not total three. Maximum acceptable. Okay. Acceptable FVC should be smooth, continuous, and complete. So this is FVC. Okay. So normal tidal breathing. Then patient asked to take maximum breath here from here to here, and lungs reached actually TLC. Then asked him to blow rapid, fast, and continuous. So like rapid, like that. So just blow, 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 blow. It should be continuous. No hesitancy, no anything. It should be confused. So it should be smooth, continuous, complete. Exhalation must be complete, and it should be at least 6 seconds, because normal healthy person can empty their lung in 6 seconds. So 6 seconds is normal for healthy person. But some patients of COPD or emphysema, because of bronchoconstriction, because of narrow airway, so air is coming slowly. So slowly, 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 so they can exhale up to 15 seconds. Can you imagine? Normal healthy person, they cannot blow more than 6 seconds. But COPD patient, those who have severe obstruction, they can exhale up to 15 seconds because of narrow passage. And because of narrow passage, they can inhale. So when to terminate the test? Say for example, if this straight line is coming, then we can terminate. If it is not coming straight line, plateau is not achieved, then we have to see that increase in volume. If it is less than 25 ml in 1 second, then we can stop air. So minimum 6 seconds. After 6 seconds, either plateau should be reached, or there is increase not less than 25 ml in 1 second. Then we can stop test. Okay. Then what to see for acceptable criteria, for acceptable, whether the graph is acceptable or not. So first and second, FVC and FE1, it should be not more than 150 ml difference between two. So less than 150 ml. If FVC or FE1 is more than or less than 150 ml than that of other graph, then that graph is not acceptable. We have to repeat spirometry again. Okay. So we should not accept if patient is having cough at expiration, Valsalva manure, obstructed mouthpiece while performing FVC. We should repeat test if this occurs. Okay. And another thing is that FIVC means the vital capacity in inspiratory phase, because what we are exhaling, prior to exhaling, we are taking inhalation. So inhalation should be complete. Then only we can expect normal FVC. So technically, inspiratory phase of vital capacity like should be equal to exhalation FVC. Okay. So FIVC must be equal to FVC. Expiratory and inspiratory should be both same. Not difference should not be more than 100 ml. It should be less than 100 ml of 5% of FVC. If FIVC or FVC they are not equal, it means patient didn't take complete inhalation. then it will give falsely reduced FVC. Because patient not taking FIVC, then how will he will blow the air? So FIC and FVC should be equal or less than 100 ml difference. So as I told you, we have to repeat, we have to do 3 acceptable spirometry. Now, it should be rapidly, fast, start fast, no hesitation, sharp peak, no cough, glottic closure in the first second. And it should read end of test criteria, means there should be plateau in expression or increase in volume should be less than 25 ml per second. Then only we can end spirometers. So this is the A1 is normal spirometry curve because patient has started rapidly, blow, and this is peak. Then smoothly flow has reduced. Okay. In B, what happens? Patient hesitate to start. The patient has started, then stop, then again started. We should discard this spirometry. Another one is poor initial effort. We should not accept this graph. Fourth one is rainbow curve. This is same or same. Patient didn't exhale forcefully. And E is there is patient has started rapidly, very good, flow is good, but at the end of expiration, patient stopped expiration. Okay, patient hold it. So flop, the flow dropped suddenly. And F, patient had cough at the end of expiratory phase. G, patient has taken, patient is expiring normally. Then suddenly he stopped exhaling, again started. So for a moment of for few seconds, for many, the fraction of second, he stopped exhaling. We should discard B, C, D, and E, G. So we can accept cough in the later part of exhalation. Otherwise, we have to repeat PFT, I mean spirometry in these other conditions. So now question is, once we are doing three FVC trial, which one to be used for interpretation? Because this is 3 trial, 1, 2, 3. And all 3 should be acceptable. Means their FVC and FE1 should be less than, difference should be less than 150 ml. So all 3 are acceptable. Which one should be used? So guideline says the trial which is having maximum FVC, we should take FVC from this trial. The trial which is has more FE1, we have to take FE1 from that trial. It may be different because FVC we are taking from trial 3, FE1 we are taking trial from 1. So we have to calculate ratio of this. Ratio FE1 and FVC. So 4.41 divided by 5.35. So we have to use this ratio. Okay. For other parameters like FEF 25 to 75%, this other. So we have to take the trial which in which the addition of FEC and FE1 is more. We have to add both FVC and FE1. Which give more result, we have to take that trial for interpretation of other things. Now, how to read curve or spirogram? This is very important question for your Viva as well as for practical life, because we have to see curve and spirogram, and by spirogram we can tell that patient is normal or having any problem. Okay, so there are 2 type of curve: flow volume curve and classic spirogram or time volume curve. And these both graph should be included in the report. So this is normal volume time graph. So time is there in x-axis, volume is in y-axis. Okay, so as I told you, patient have to take deep breath, then patient has to blow, patient has to expire rapidly, fastly. He has to blow very fast. So you can see the volume he he will expire very fast. So in 1 second itself, he will expire around 80% of his FVC. Okay. Say for example, if FVC is 5 liter, so normal individual can empty their lung in 1 second about 75 to 85%. Normal individual. But for diagnosis criteria, FE1 should be more than 70% of his FVC, not another one as FVC, their own FVC. If my FVC is, say, for example, 3 liter, so 70% should be FE1, around 2.25 liter. Okay. If my capacity is FVC 10 liter, FE1 should be more than 7 liter. So my own FVC, I should blow FE1 more than 70%. That is normal. Okay. So patient started blowing in 1 second, he can blow around 75 to 85%. In 2 seconds, around 90 to 95%. In 3 seconds, almost 100%. Can you see? Almost 100% he can throw air out of the lung. Okay, so we are doing for 6 seconds. For practically normal individual can exhale within 3 seconds his whole FVC. Normal flow volume. Okay, flow volume, x axis is volume. Okay, in y axis flow. Okay, so x axis volume. So I told you that patient has to expire up to residual volume and inhale up to total lung capacity. Say for example, if we are taking normal tidal breathing, we have to inhale, full inhale up to TLC. Then we have to exhale very forcefully. Flow rate is maximum, very high flow rate, maximum flow rate. So maximum flow rate is, then after maximum flow rate automatically decreases, and the end of residual volume, it becomes zero. Then again inspiratory phase up to TLC. So this is whole one cycle. Inspiratory phase, expiratory phase. So you can imagine when patient is blowing air out the air, there is maximum flow. That peak is called PEFR, peak expiratory flow rate, maximum flow rate. After that, it decreases. Okay. So if we divide this volume, say for example, some patient is having FVC of 4 liter. So we divide this XXX line in 4 parts: 25% volume, 50% volume, 75% volume, 100% volume. 1 liter, 2 liter, 3 liter, and of course 4 liter. Okay. Then we have to see flow at the 25% of force vital capacity. What is the flow rate at this point? The flow rate is this. Okay. And what is the flow rate at 75% of FVC? Flow rate is this one. Okay. So this flow rate, 25% to 75%, is called FEF 25 to 75%. This from here to here. Okay. So this is mid expiratory flow rate, or FEF 25 to 75%. So what the significance of this? Okay. So significance is this: when we are blowing out, when we are expiring, so first the volume comes from our large airway, like trachea, main bronchus, lower bronchus. Okay, coming sequentially. Then later part of exhalation comes from small airway. So first large airway, then medium airway, then small airway. Air come like that. So when the patient is starting blowing, initial part is coming from large airway. That's why the peak, the flow rate is very high, because it comes from large airway. There's no problem to expire from large airway, larger lumen size. The problem is in small airway cells. Okay, so flow rate is less in less in small airway. Okay, so small airway FEF 25% to 75%. So if there is small airway obstruction, so what happens? The flow rate will be reduced. Which one? Middle expiratory flow rate. So like the curve is like coming this. So in small airway obstruction, the flow will come like it will come like that, like that. There is concavity. So if you find concavity in expiratory phase, especially in mid expiratory flow rate, so this will be suggestive of small airway obstruction. I think I am clear. Okay. Can you tell where is FE1 here in this graph? So maximum people what they say FE1 is here, but the answer is wrong. Why? Because as I told you earlier, normal individual, when this graph is normal, it means normal individual can blow 80%, at least 80% of his vital capacity in 1 second. And where is 80%? 75 here, somewhere here, 80%. So at 80% of FVC, his flow rate is around this one. So here it is FEV1. Okay, FEV1 is not here, is here because 80% he has blow in 1 second. FE1 here. Here is FE2, FE3, and small is FE4, 5, 6. Up to 6 seconds we have to blow. So this is normal flow volume loop. I think I am clear. Okay. So in spirometry, we have to focus on three values: force vital capacity, FE1, and FE1 by FVC ratio. And we can see two flow: peak flow expiratory rate and FEF 25 to 75%. So we will discuss one by one. Okay. So where spirometry usually being done to rule out obstructive versus restrictive pattern. This is for screening. Spirometry will tell whether restrictive pattern is there or not, whether obstruction is there or not. For further evaluation, we have to do another test. Okay. So you imagine this is our lungs, alveoli, and this is the airway. Okay. So in alveoli, this is holding all air which we are exhaling forcefully. That is FVC. Okay. So FVC, patient has to blow his FVC through this airway. Okay. So more than 70% of FVC he can blow this airway, and this is called FE1, 1 second. Okay. So normal individual can blow his normal FVC in 1 second around 80%. So normal FE1 is 80% normal. If any condition which narrow this passage, this airway obstruction like asthma or COPD. So alveoli are normal. So FVC is normal, capacity is normal, but the lumen is narrow. So patient will take more time to exhale. So he cannot blow more than 70% in 1 second because passage is narrow, lumen is narrow. So he cannot expel 80% or 70% in 1 second. So here FE1 will be reduced. Okay, when FE1 will be reduced, ratio will be reduced. FE1 by FVC ratio will be. Okay, see in this condition, here airway lumen are normal. See, this is normal. But the alveolar size is get reduced, means reduce FVC. Patient is not having enough capacity to hold FVC. FVC size is reduced. When FVC size is reduced, so patient can blow its 80% from this lumen in 1 second. So what will happen? FE1 is normal, 80% of his FVC. Okay. In last condition, both are reduced. Alveolar size is reduced, and airway is also narrowed. So in this case, FVC is also reduced, FN also reduced. So there is restriction and here is obstruction. So mixed pattern. So this is normal, this is obstruction, this is restriction, and this is mixed pattern. I think I am clear. So normally, normal airway, when airway is normal, vital capacity is normal. So in 1 second, patient can blow more than 70% in 1 second. In 2 seconds, almost 95%. 3 seconds, almost 98% to 100%. So maximum in 1 second, then little one 2 seconds, and after that, patient is that line is flat. Plateau is there. Patient cannot blow more than this. So FVC reach is 2 seconds. This is normal airway. What happens in obstruction? Obstruction means narrow airway. FVC is normal, alveolar size is normal, but the narrow passage. When passage is narrow, that cannot blow more than 70% in 1 second because FVC is same, alveolar size is same, but very narrow passes. He cannot blow, very narrow passes. So no, in obstructed airway, FE1 is less than 70%. So say for example, 50%. Another 1 second, 25%. Another 10%, 5%, 2%, like that. So patient in case of obstructive lung disease will blow up to 6 seconds. Normally, 2 seconds is enough for empty the lung, or 3 seconds is enough. But obstructive disease, up to 15 seconds he can take. The severe obstruction, he can take up to 15 seconds. This is obstructive airway. So if you see volume time graph, this is normal. As I told you that in 1 second, patient can blow more than 70% of FVC. This is FVC. If you see this graph, this is around 85%. So FE1 is 85%, FVC is 100%, ratio is normal. Okay. So you can see this yellow graph. 1 second, this is less than normal, less than 70%. This is mild obstruction. If there is more obstruction, then this FE1 further reduces. In severe obstruction, further reduction in FE1. So ratio will be less because FVC is normal, but FE1 is less. So there will be reduction of FE1 by FVC ratio. So mild, moderate, severe. So this is flow volume curve. Okay. Flow volume curve, I told you this is total lung capacity, this is residual volume. Okay. Patient will exhale rapidly. Okay. So this line is normal. This light green line is a normal. This is peak expiratory flow rate. This is mid expiratory flow rate. If there is mild obstruction, I told you either mild obstruction or small airway obstruction, there will be concavity in mid expiratory flow rate. Okay, just mid expiratory flow rate. Peak expiratory flow rate will be normal, but there's concavity. In moderate obstruction, the patient will not achieve peak expiratory flow rate. Okay, so there is further concavity. Okay, and there is normal FVC. But in case of severe obstruction, there will be reduction in FEF, this peak expiratory flow rate, and there is increase in concavity. And patient will not achieve to FVC also because before achieving FVC, airway will get collapse and that will cause pseudo reduction in FVC. So this is also called air trapping, seen in case of emphysema. So this is mild, moderate, severe obstruction. As I told you, if there is concavity in mid expiratory flow rate, this is small airway obstruction. Okay, so we can see why FEF 25 to 75%, force expiratory flow rate between 25% and 75% of FVC. Okay, but this is not reliable. Reliable only if there is good effort. And normal is 75, more than 65%. If less than 65%, then we can think of small airway obstruction. Now, restrictive pattern. As I told you, restrictive pattern is there is reduction in FVC. Patient cannot inhale maximally, so there will be reduction in FVC. Say, for example, ILD, interstitial lung disease, pleural fibrosis, thickening, or skeletal disease like kyphoscoliosis. So, because of kyphoscoliosis, patient cannot exhale maximally. If patient not taking breath, he cannot blow also. So, there reduction in force vital capacity. Okay, so you can see normal residual volume, total lung capacity. So, patient this vital capacity is reduced. Normal is from TLC to RB, but in this case, it is reduced TLC to RB. So total FVC is reduced. But you can see whatever FVC is there, FV1 is normal. So he can blow up to 80%. So if you see ratio of FE1 by FVC is normal. If you compare within patient FVC is reduced, so FE1 is normal for that FVC. But if you compare with other person, then FE1 also reduced. Okay. If you see time volume graph, so time volume graph is, so you can see this is forced vital capacity. This is normal. Dotted one is normal. Blue one is reduced. Reduced in restrictive lung disease. So forced vital capacity is reduced, but you can see FE1 is normal. Okay, this is FE1. 1 second is here. So 1 second is around 80% of FVC. So ratio will be normal or increase, but FVC will get reduced. So this is restrictive pattern. Variable, I mean upper airway obstruction. If there is obstruction in upper airway like trachea or large airway, so this is three type: variable intrathoracic, variable extrathoracic, and fixed airway obstruction. So by looking flow volume graph, we can identify. We need not to see values. By seeing graph, we can identify. So in fixed obstruction, there will be reduction in air flow in both phase, expiratory phase and inspiratory phase. So you can see there's flattening of flow in expiratory phase as well as inspiratory phase. This is fixed volume, fixed obstruction. If there's extrathoracic obstruction, then problem is in inspiratory phase. So this is just opposite, extra intrathoracic, intra exhalation, extra inspiration, intra expiration. This is opposite. Okay. So if variable extrathoracic obstruction, the problem flattening of line in inhaled part, but exhalation is normal. If it is intrathoracic, then problem is in expiratory phase. Inspiratory phase is normal. Example, fixed obstruction, bilateral vocal cord palsy, thyroid swelling, any growth, any tumor which obstruct trachea or major airway. Vocal cord dysfunction, extrathoracic variable, because this is outside of thorax, is here neck. If there is blow neck, intrathoracic, then problem is in either tracheal tumor, mediastinal mass, or lymph node, mediastinal lymph node. So below neck is intrathoracic, outside within neck, this is extrathoracic. So this is how we have to see by looking flow volume curve. So this is example, this is normal peak, smooth graph. This is normal spirometry, inhalation, exhalation. If you see this one, so this one you can see there is less peak and there is concavity, but FVC is normal. This is obstruction because peak is less, concavity means mild to moderate obstruction. Here, further concavity and reduced peak, reduce FVC also. This is emphysema, severe obstruction. In severe obstruction, FVC also reduced falsely, pseudo reduction. And this graph, this is, you can see normal expiratory phase, but problem in inhalation. The problem in inhalation means extrathoracic obstruction, variable extrathoracic obstruction. Here you can see the problem in expiratory phase as well as inspiratory phase. Both got flat. This is fixed upper airway obstruction. Here you can see there's good peak and slight concavity. Here inspiratory phase also, this is like a similar pattern. So this classical graph is seen in unilateral mainstem bronchial obstruction. If there is unilateral bronchial obstruction, you will find this graph. So by seeing this graph, you can diagnose the patient. In this graph, you can see very beautiful peak, but the reduction in FVC. Can you see this FVC reduction? This is not. This is normal peak. FE1 is normal, but FVC reduced. So this is restrictive pattern. Here you can see there is reduction in FVC. Normal it was 4. Normal reduction in FVC, and here is concavity and reduced peak. This is case of mixed disorder. So this is example of obstruction as well as restriction. So once you get spirometry report, first we have to see FE1 by FVC. If FVC is normal, FE1 is reduced. It means there is obstruction. So if ratio is less than 70%, then this is obstructive airway disease. But we have to remember, we have to see absolute ratio, means ratio of patient FE1 by FVC, not percentage. Okay. So if we absolute value is less than 70%, then this is definitely airway obstruction. If additional restriction is there or not, we have to look for FVC. If FVC is normal, then there is pure obstruction. Let it be mild, moderate, or severe. Okay. If FVC is reduced, then there is obstruction as well as restriction. But to confirm restriction, we have to do lung volume studies. We have to look for residual volume and total lung capacity. But if there's obstruction and reduced FVC, there's another condition, severe obstruction, where I told you that there is false reduction in FVC, because that before completing exhalation, airway get close. So patient not able to blow whole air. That causes reduction in FVC. That will seen in severe obstruction. If ratio is normal, so if ratio is normal, definitely obstruction is ruled out. Then we have to see FVC. If FVC is normal, so there is no obstruction, no restriction, normal spirometry. If there is reduction in FVC, then this feature is called restrictive pattern, not restrictive lung disease. And to diagnose whether restrictive lung disease is there or not, we have to do total lung capacity. I'll discuss in another class. So by and large, by studies says 40% of restrictive pattern are real restrictive lung disease, like interstitial lung disease or kyphoscoliosis. Rest 40% are normal, and this is called prism. Prism I'll discuss in another slide. Okay, so by and large, if ratio is less, then there is obstruction. Ratio is normal, either normal or restriction. So how to see reversibility? So reversibility in case of obstructive lung disease. So if you find obstructive lung disease, we have to do bronchodilator reversibility test. And we have to give salbutamol 200 to 400 microgram or ipratropium. We have to wait for 10 minutes at least, and we have to repeat spirometry again. If there is improvement in FE1 or FVC by 12% and 200 ml, then this called positive bronchodilator reversibility test, positive BDR. If there is improvement less than 12% and 200 ml, then this is called partial BDR. If there's very less improvement, then this is called negative BDR, negative bronchodilator reversibility test. So if FVC improve more than FE1, indicate opening of small airways obstruction, likely to be COPD. So what is the difference between asthma and COPD? Asthma is a reversible disease. If you give bronchodilator, if FE1 FVC ratio become normal after bronchodilator, this is asthma. If after giving bronchodilator, if ratio is less than 70%, this is COPD, because COPD is irreversible disease. But in children, we take 85%, not 70%. So even if positive bronchodilator reversibility test is there, then also if ratio is less than 70% after bronchodilator, then this is COPD. Even significant BDR is there, then also it is COPD. But after BDR, if it is more than 70%, then only we label as asthma, because asthma is fully reversible, not partially reversible. So severity, this is old rule. Asthma 60-80. So more than 80 is mild, 60 to 80 is moderate, less than 60 is severe. COPD 30-50 rule, because this is gold guideline, 80-50-30. So this is old guideline. So I'll discuss new guideline. So there is guidelines ATS ERS 2022. This is new update. So I'll discuss this update. So there is concept of Z score or lower limit of normal. So this is normal distribution of data. If you take 1000 patient, so we take 1000 patient, this is normal distribution. So this is lower limit of normal, this is upper limit of normal. So normally patients should fall between LLN and ULN. This is normal. And this is called Z score. Okay. So Z score normally lower limit is 1.65. Upper limit is plus 1.65. So plus 1.645 minus 6.45. If data falls in between this LLN and ULN, then that is normal. Outside this range is abnormal. So we that according to new guideline, every report should be reported in Z score. So for all measure, we use Z score. So mild is 1.65 to 2.5, moderate is 2.5 to 4, and severe is more than or less than 4.1. So we have to remember three value: 1.65, 2.5, and 4. So value should fall between minus 1.65 to plus 6.5. Beyond that is mild, moderate, severe. 2.5, 2.5 to 4, 4, more than 4 is severe. So we will interpret it by this only. So according to new guideline, we should interpret report by lower limit of normal, 5th percentile, or ULN 95th percentile. So LLN is called 5th percentile and upper limit of normal is called 95%. So our data should fall in between this cutoff only. So instead of using fixed ratio, we have to use LLN. Okay, lower limit of normal. Then bronchodilator response test. Previously, as I discussed, it was 12% and 200 ml from baseline. But now this is more than 10% of predicted value of FE1 or FPC. So this was baseline from a patient value, but this is from predicted. How much should be there? If there's increase by 10%, then is BDR is positive. So it was 12% at 200 ml. Now this is 10%. So 10% of predicted value. So for mild, moderate, severe, instead of fixed percentage, we have to use Z score. As I told you, 1.65, 2.5, and 4. So this is example of bronchodilator response. Now we are not saying bronchodilator reversibility test now. So we are telling bronchodilator response test, not reversibility test, because after giving bronchodilator, it may not possible to reverse completely. So this is response BDR. Okay. So if we take example, this is patient and pre-bronchodilator FE1 is 2 liter. After bronchodilator, this is 2.4. So if you calculate by our old method, it should be 20% because 2.4 post and pre 2 divided by 2. So there is improvement by 20%. But by new concept, 2.4 post bronchodilator minus pre bronchodilator upon predicted, because at this age, sex, height, patient should have 3.3 to normal FE1. So we will divide it by this. It is 12%. Okay. So old method 20%, new method is 12%. So now interpretation. So interpretation, before interpretation, we should know clinical history, parameters like age, sex, height. We have to see loop and graph because 50% of idea we will get by loops and graphs. Then we have to see reports. So by new method, first we have to see ratio. If it is more than fifth percentile, okay, if it is more than 1.65, then it is normal. If ratio is more than fifth percentile, yes, then there is no obstruction. Then we have to see FVC. If FVC is reduced, then this is possible restriction. If it FVC is normal, then normal spirometry. If ratio is less, then there is obstruction. For restriction, we have to see FVC again. If FVC is normal, pure obstruction. If FVC is reduced, then mixed pattern. So we will interpret report one by one. So can you see? So first we have to see clinical history. We have to see whether this was inserted correctly or not. So COPD with hoarseness of voice. So we will get idea what could be the report. So by loop you can see there's normal expiratory phase, but inspiratory phase there's flattening. So this is case of variable extrathoracic obstruction because extrathoracic their problem is in inhalation. Now this report we have to see clinical history. So age, sex, height, all are good. Then we have to look for graph. So graph is okay, is normal. Okay. If you see carefully, FVC is fall in this shaded area, gray area. So FVC is normal. So in this graph, we have to see whether patient has expired 6 seconds or not. So you can see that patient has expired about 5 seconds. So we can interpret it because there is no increment of FE1 more than 25 ml per second. This is almost flat 9. So we can interpret a 5 second also. So once we see value, in value we can see the first we have to see ratio. This is ratio. So ratio Z score is 2.34. This is normal. No, this is increase. So minus 1.65 to plus 16.5 is normal. 1.65 to 2.5 is abnormal. So this is abnormal. So FE1 FVC is increased. Now, once ratio is normal or increased, we have to look for FVC. FVC Z score is minus 2.35. So this is minus reduction in FVC. So 1.65 to 2.5. So this is mild restriction. Okay. So this is mild restriction. This case is mild restriction. Well, after giving bronchodilator, we can see ratio is 1.06. I mean 1.18. Ratio become normal. FVC, FVC is also got normal 1.65 within 1.65. So after bronchodilator, this is normal spirometry. This is for eyeballing, quick inspection of patient. So this is green area is normal. This reddish area is abnormal. So you can see FVC red area and these are normal area, green area. Okay. Post bronchodilator, all three are in normal area. So post bronchodilator is normal. So now this report, we have to see first clinical history, age, sex, height, all are filled correctly. Then graph. Graph is very small, but patient has blown up to 5 seconds. there is straight line, no, there is plateau. So we can interpret this report. Okay, by seeing this graph itself, we can say that the reduction in FVC, definitely restriction is there. So if you see this report, then first we have to see ratio. The ratio is 1.19. Ratio is normal within 1.65 plus minus 1.65. Then we have to see FVC. FVC is minus 3. It means FVC is less because 1.65 to 2.5 is mild, 2.5 is to 4 is moderate. So this is moderate restriction. So our answer is moderate restrictive pattern. Now case number 3. So clinical history, hair, height, weight, all are filled correctly. Graph pre is not good, but post is good. And expiratory time is normal. 6 seconds post bronchodilator is normal. So once we see value, so ratio is normal 1.93. So 1.65 to 1.65 normal. After ratio is normal, then we have to see FVC. So FVC is normal. But if you see carefully, FE1 is reduced. So normal ratio, it means obstruction is ruled out. If isolate FE1 is less, it means it is prism. This is preserved ratio impaired spirometry. Okay. So what the significance? Most of the prism converted into obstructive lung disease in their later life. So this is like a pre-COPD. Okay, risk factor for COPD. After giving bronchodilation, ratio is normal, FVC is normal, FE1 is normal. So this is pre-prism, post is normal. Probably this is early obstructive ABDs. That's why it responded with bronchodilator. Now this report. So in this report, you can see this is vocal cord paralysis. So graph you can see the flattening of inspiratory phase as well as expiratory phase as well as inspiratory phase. So this is fist obstruction. This case you can see tuberculosis with mediastinal lymphadenopathy, and by this history you can understand there should be medial lymphadenopathy means there intrathoracic obstruction. If the intrathoracic obstruction, there is flattening of expiratory phase. Inspiratory phase is normal. Expiratory phase is flattened. This is variable intrathoracic obstruction. Now this one. So A, sex, all are correct. Now this graph is okay. Patient is blown up to 18 seconds. Okay. So we can interpret it. So ratio is 1.3 normal. FVC is normal. And there is reduction in FE1 because this is less than 1.65. So less than 1.65, FE1 is less than 1.65, but ratio is normal. Okay, so again, this is prism. There is no obstruction because ratio is normal, no obstruction. This is prism. And after bronchodilator, all ratio become normal. If you see eyeballing, this is normal, all falling green. So post bronchodilator is normal. So here you can see all are correct. Age, height, weight, graph is okay. Then we have to see report. So ratio is normal. FVC is normal. FE1 is normal. This is normal report. Okay. Now here. Here, if you see graph carefully, then graph going peak. Inspiratory phase is not good, but expiratory phase is good. So once we see report, ratio is normal, 0.82. FVC is 1.41. This is normal. So this is normal report, pre and post. Okay. So we'll skip some example. Yes, this report. So in this report, height weight is all good, and this graph is okay. There's good graph, and this expiratory phase is good. 12 second he has blown. So once we'll see report, there is reduction in FE1 by FVC. This is obstruction. And here we can see FVC is normal, FE1 is abnormal, 0.64. This is less than 4. This is severe obstruction. Okay. After bronchodilator, ratio is again less, but the improvement is FE1 by 64%. This is significant BDR, significant bronchodilator response, but still there is moderate obstruction. So pre is severe obstruction, post is moderate obstruction. Since this is positive BDR, this is good response with bronchodilator reversibility test, but this is not asthma, because in asthma this ratio should become normal. F1 FVC ratio should become normal, but this is not normal. This is COPD with positive bronchodilator test. So this case you can see height, weight all are normal. So graph, okay. So once we'll see report, the ratio is reduced 4.93. So there is definitely obstruction. FVC is reduced. FE1 is also reduced. This is mixed pattern because all three are reduced, mixed pattern. After bronchodilator, ratio is less, but you can observe FVC become normal. Okay, FE1 is still less. So what you can think of? So this is pre-bronchodilator mixed pattern. Post is moderate obstruction. There is no restriction. It means with bronchodilation, with bronchodilator, FVC improved. It means there is no real reduction in FVC. There is pseudo reduction in FVC. That's why it's improved. It's a stage of emphysema. So to summarize, again, we have to look for FE1 by FVC ratio. If it is normal, then we have to look for FVC. FVC is normal, normal spirometry. FVC is less, restriction. If ratio is less than 5%, then there is obstruction. After obstruction, we have to see for FVC. If FVC is reduced, then this is mixed disorder. If FVC normal, pure obstruction. I hope you understood spirometry. So if you like this video, please share with your friends. And that's all in this class. See you with another video next class. Thank you very much.